Induction of labor. A definition: artificial termination of pregnancy by inducing labor. Indication: whenever continuing pregnancy will harm the mother or the fetus. Example: post-term pregnancy, premature rupture of membrane, chorioamnionitis, medical disorder like diabetes mellitus, hypertensive disorder, chronic nephritis or acute renal failure, jaundice with fetal distress as congenital fetal malformation, intrauterine growth restriction, intrauterine fetal death. Antepartum hemorrhage not suitable for conservative treatment. Factors affecting success of induction. Bishop score. The Bishop score takes accounts of the cervical length, cervical dilatation, cervical consistency, cervical position and station of the fetal head. A score of 9 or more is favorable for labor induction. Albarity. The induction of labor is easier in multi-gravida than primigravida age, easier in younger age than elderly. Fetal maturity, gestational age. The more mature, the better result due to higher estrogen levels. Methods of induction. Artificial rupture of membranes plus syntocinon are better than any method alone, and prostaglandin are better than all. Methods of induction. Preterm delivery with all complications of prematurity. Cervical ripening by prostaglandin. Prostaglandin are effective in inducing cervical ripening, softening of the cervix of the cervical collagen fibers, which effectively results in success of labor induction. Prostaglandin E2, vaginal tab or gel, prostaglandin A1 misoprostol, vaginal tablet inserted into the posterior fornix. Repeated small doses of misoprostol, 25 to 50 microgram, can be used to induce uterine. Amniotomy. Artificial rupture of membrane. This is done to initiate or augment labor or to allow fetal scalp blood pH assay. The cervix must be at least 2 cm dilated to allow safely performing amniotomy. Amniotomy appears to release a local secretion of endogenous prostaglandin. It is done by passing special hook along the fingers or by direct fission using a speculum to rupture the membrane overlying the presenting part. But the care must be taken not to damage cervical or fetal tissue. The color and quantity of the liquor removed should be noted. Labor may not become established after amniotomy alone, and it is usually stimulate the uterus further by IV oxytocin if contraction are late. This is the picture of complication of amniotomy. Placental separation abruptio may be caused by sudden reduction in intrauterine pressure, especially in polyhydramnios. Vaginal bleeding, soft tissue, and fetal injury should be excluded. Prolapse of cord, especially in ill-fitting presenting part. Fetal heart rate monitor is a must after amniotomy. Infection. Intraamniotic infection may occur if the interval from amniotomy to delivery is excessive and both mothers and child are at risk. Careful antiseptic technique and prophylactic antibiotics are strongly recommended whenever delay is. IV oxytocin drips. Synthetic oxytocin by continuous IV drips is commonly used after amniotomy to stimulate uterine contraction. Dosage should be carefully titrated and monitored as the drug is powerful and uterine response to stimulation is generally unpredictable. IV oxytocin is best administered by suitable semi-automated infusion system incorporating an accurate drop. Other methods: stripping of membrane, breast massage, sponge tent in the cervix, laminaria tent, tampon in the cervix, and so on. Complication: failed induction. This increase cesarean section rates, iatrogenic prematurity if gestational age was not assessed accurately. Complication of each method used, like amniotomy, prostaglandin, syntocinon.